Well, good morning, everybody. Welcome to the Department of Medicine Grand Rounds. I'm very excited. We're going to have one of our very own faculty members present this morning. So I'll turn it over to Dr. Dinesh Kalra, the Division Chief for Cardiovascular Medicine, to introduce our speaker.
Thank you, Dr. Cook, and welcome everyone to the January edition of our Medicine Grand Rounds. And today it's my pleasure to introduce Dr. Jishanth Mattumpuram, who, as you heard, is an assistant professor in our division. Dr. Mattumpuram is also the associate program director of our fellowship program. In terms of his background, he obtained his medical degree from the Calicut University in India, and then he did an internal medicine residency there at the Government Stanley Medical College in Chennai, India. And Dr. Mattumpuram, as you'll see, is a scholar. So when he moved to the United States, he did another medicine residency, which he completed in 2019 from Cook County Hospital in Chicago. And then he finished his cardiology fellowship at the University of Illinois, UIC, in Peoria, Illinois, and completed that in 2022. And then he joined us subsequently. He has a special interest in preventive cardiology and cardiology imaging, and he's board certified in a lot of things: cardiology, nuclear cardiology, cardiac CT, cardiac MRI, and vascular imaging. And as you would imagine, his expertise is in those areas, as well as preventive cardiology and hypertrophic cardiomyopathy. And he's going to talk to you today about cardiomyopathies. Dr. Mattumpuram is a fellow of the American College of Cardiology, the American Heart Association, the American Society of Echocardiography, the Society for Cardiovascular CT, the Society for Cardiovascular MRI, and the Society for Nuclear Cardiology. As I mentioned, he's never one to stay still or rest on his laurels, so he went on to do a Master's of Science in Clinical Investigation after he joined us here, and he successfully completed that at the UofL School of Public Health and Information Science in 2025. And he's very active in the publishing space. He's had more than 50 peer-reviewed publications, and he serves on the editorial board of the journal PLOS 1. And with that, I'm going to turn the floor over to Dr. Mattumpuram to talk to us about cardiovascular genetics in cardiomyopathies. Jishanth?
Thank you, Dr. Kalra, for your generous introduction, and thank you, Dr. Coach. And I would like to take this opportunity to thank the Department of Medicine as well as the Division of Cardiology for giving me this incredible opportunity. To begin with today's cardiomyopathies and an introduction to the genetic evaluation of cardiomyopathies. And to begin with, I do not have any financial or other conflict of interest to disclose. At the end of today's session, I would like everyone to walk out with a newer perspective on inherited cardiomyopathy so that we can serve a small subset of population way better than what we do right now with renewed knowledge. I'll be going over some of the current definitions, including the etiologies, appreciate the limitations of current definition, and a more perspectives on multi-modality imaging and how we can change the way we are managing cardiomyopathies right now, and the importance of deep phenotyping as well as re-phenotyping these patients, the role of cascade clinical and genetic evaluation of family members, and understand a little bit of the challenges in evaluation, especially because of different modes of inheritance, variable expressivity, and incomplete penetrance of this genetic disorder. I would also like to make everyone be aware of the management principles and need for referral to specialized centers if that is needed. Let me begin with a simple case, which I probably encountered a year ago. A 29-year-old male was referred to my clinic for a routine evaluation, but over the last 2 years, his supervisor had been encouraging him to get one because he's a firefighter, and every time there was an emergency, when sending this patient, he always had some doubts in his mind. He's a professional bodybuilder, so very conscious about his health. He denied any history of syncope or any difficulty in effort tolerance at baseline. He has no family history of sudden cardiac death or other cardiomyopathies. This was the initial EKG. What I could decipher was probably the chief was true in terms of his perspective that, during one of his routine health evaluation, he was recommended to undergo something based on his EKG. So when I looked at the EKG, he had an underlying right bundle branch block along with the left anterior fascicular block with some left axis deviation. Now, for a 29-year-old, otherwise healthy male, should we bother a lot about this one? Probably not. But my conscience was like, he is going into a high-risk job, and you don't want anything to happen to him. So I sent him for a exercise stress test along with the echocardiographic. And to our surprise, as soon as he started walking, he started showing a lot of premature ventricular contractions, and at least a couple of times he developed non-sustained ventricular tachycardia. He was clinically very stable, no symptoms. He completed the study. I looked at the echocardiogram, and to my surprise, his ejection fraction was low normal. However, there was no wall motion abnormality that I could decipher at the end of the stress test. Now, same day, I recommended him to undergo a 14-day event monitor just to understand him a little better. So the Holter monitor turned out to be otherwise unremarkable, except for a few episodes of non-sustained VT as well as 2% burden of PVC. Now, let us go to the outline of cardiomyopathies. I will discuss definitions. I will touch upon some of the subsegments like hypertrophic cardiomyopathy, dilated cardiomyopathy, arrhythmogenic cardiomyopathies, LV non-compaction, and some restrictive cardiomyopathy. Each of these topics are a topic of discussion of an hour. So, I understand my limitation. And ultimately, my goal will be to introduce to some of the role for genetic testing. So, by definition, cardiomyopathies are primary morphological and or functional disorders of heart muscle. And it is important to note that it's not secondary to coronary or valvular heart disease, hypertension, or congenital heart disease. So we have to rule those things out. Now, the most widely accepted classification is from the European Society of Cardiology. Remember, despite this being from 2007, we still continue to follow. Although there have been several interim reports from WHO as well as ACC, AHA in order to redefine cardiomyopathies. This is still the standard classification that we follow. Now, because it is 2 decades almost up, that itself points to some changes which might be coming soon in the guidelines. However, to begin with, it is a morphology-based classification, primarily dividing it into hypertrophic cardiomyopathy, dilated cardiomyopathy, arrhythmogenic right ventricular cardiomyopathy, restrictive cardiomyopathy, and a last class as unclassified. Now, several disease entities like peripartum cardiomyopathy, Takotsubo cardiomyopathy, as well as some other specific cardiomyopathies, we are not touching because they all have a different pathophysiologic process, which are not inherited and have other etiology factors. However, regardless of which category patients belong to, we can divide these into either a familial/genetic variant as well as non-familiar or non-genetic variant. Now, if we subclassify and do more evaluation, we'll have specific subtype among these diagnoses. And, ultimately, everything comes down to whether it has a specific etiology or there is no etiology. Historically, we used to call them as idiopathic cardiomyopathy, and to date, even now, we are still calling either non-ischemic cardiomyopathy or idiopathic cardiomyopathy. So that is where the real challenge is to reclassify these patients so that we can treat them better, serve them better. So as I said, this is morphology based. You can see on the upper left corner a classic hypertrophic cardiomyopathy where there is a increased septal thickening. And hypertrophic cardiomyopathy can have several variations depending on where the hypertrophy is. But in general, they are normal sized LV, usually normal sized RV, however thick heart muscles. If you look at the right upper corner, dilated cardiomyopathy, by definition, it is a dilated left and or right ventricle. So biventricular dilation. In the advanced stages, you can see the both right and left atrial dilation as well. On the right lower corner, you can see classic restrictive cardiomyopathy. These are, by the way, MRI images. Restrictive cardiomyopathy where there is a normal sized ventricle, both left and right, but severely dilated atria because of restrictive physiology. Arrhythmogenic right ventricular cardiomyopathy is a distinct subset among the arrhythmogenic cardiomyopathies. You can see the right ventricle as big as the left ventricle. In addition, there are several changes, including fibrofatty infiltration as well as scarring on the specifically involving the right ventricle. Last but not the least, left ventricular non-compaction is increasingly being recognized, and in the previous classification, it belonged to the unclassified segment. However, this is characterized by increased LV trabeculation. To date, there has been no consensus definition. However, there are more genes being depicted in the etiology, and we are yet to know more about it. But the classic feature will be LV non-compaction, either picked up by cardiac MRI or echocardiogram. Remember, this is seen also normally in pregnant patients as well as athletes. So there is a growing sense that this is not a disease pattern as such. It is a phenotypic trait, and maybe it is not a true cardiomyopathy. But at the same time, we know that these people can have arrhythmia as well as sudden cardiac death. So it's a mix of both. Again, keeping a wider eye will be best option to move forward. Limitations of the current classification: there had been significant advancements in terms of genetic testing as well as advanced cardiac imaging. However, we still haven't incorporated those into the definitions. Arrhythmogenic cardiomyopathy is being increasingly recognized as a distinct entity. However, there is a significant overlap between dilated cardiomyopathy as well. And thirdly, but not least, true restrictive cardiomyopathy is extremely rare, and usually it is also associated with some form of hypertrophy as well as LV dysfunction. So, to begin with, that class may need to be reclassified in the upcoming, definitions. Diagnostic workup, a tailored diagnostic workup starting from the basic morphologic phenotype. However, these are the common elements which has to be included in any diagnostic workup for cardiomyopathy, and in a detailed history, both medical as well as family history, in order to appreciate the echocardiogram. And although we haven't gotten to a stage where we are utilizing cardiac MRI a lot, the recommendation is to begin with include cardiac MRI so that we have better reclassification as well. You can do specific blood tests to rule out other secondary etiologies, especially autoimmune versus toxic cardiomyopathies. The third step will be genetic testing, and based on genetic testing, we can do specialized testing in order to phenotype these patients a little better, like serum alpha galactosidase A for specific phenotypes, bone scintigraphy, otherwise called as the PYP scan, to delineate those people with infiltrative cardiomyopathy like amyloidosis, as well as sometimes referral to advanced neurology in order to distinguish these people if they have any underlying skeletal muscle disorder or neuromuscular disorder, because they coexist together. So this underlines the role of this multidisciplinary team in order to understand this disease better. We'll now discuss briefly about hypertrophic cardiomyopathy, clinical features, phenotypes, as well as genetics. Hypertrophic cardiomyopathy, it is a clinical diagnosis based on the presence of unexplained LV hypertrophy. As I said, we have to rule out hypertension, aortic stenosis, as well as valvular heart disease in order to diagnose any type of cardiomyopathy. By definition, adults with LV wall thickness more than or equal to 15 millimeter should be classified as hypertrophic cardiomyopathy. And if they have a family history of hypertrophic cardiomyopathy, or they have a family history with this, or they have a sarcomere genetic mutation, then their cutoff will be 13 millimeter. That means you have to diagnose them earlier so that you can institute better care for them. In children, it is based on age, sex, as well as body surface area. We use the Z-score in order to classify them as thick heart muscle. Anybody who has more than 2 standard deviation increase in the wall thickness, you can diagnose it. Prevalence, this is a decade ago was estimated to be 1 in 500. This is as equal to familial. And you have to understand that many people are walking around us with undiagnosed hypertrophic cardiomyopathy. Now, in the last 1 decade, with genotyping as well as rephenotyping, the incidence is or prevalence is increasing, to a point that most recent data suggests that the prevalence is up to 1 in 250, which is double of what we had 10 years ago. Now, it has a phenotypic predominance for males because of increased penetrance in males. Up to 60 to 65% of patients are males. These are, representative pictures. True hypertrophic cardiomyopathy. The basic pathophysiology is LV outflow tract obstruction because of the hypertrophy. There can be systolic anterior motion of the mitral leaflet during that causes an obstruction in the LV outflow tract. This is the main reason for patient symptoms, poor effort tolerance. In addition, it can be coexisting with a mitral regurgitation, and this lead to progressive left atrial dilation, predisposing them for atrial fibrillation. Now, some variants can be mid-cavitary because of the genetic mutation, the muscles are hypercontracted, and any segment can go into severe hypercontracted state and can cause mid-cavitary gradient as well. A small subset, up to 1/3 of patients with mid-cavitary obstruction, can have progressive dilation of the LV apex with remodeling as well as fibrosis, resulting in LV apical aneurysm. And the importance is that sometimes it can harbor LV apical thrombus because that segment is akinetic or dyskinetic, and many a times echocardiogram can fail to diagnose. So this is important because cardiac MRI can distinctly find this finding in testing. We all know the specific factors that make people symptomatic. Reduced preload, reduced afterload, as well as increased contractility can increase patient symptoms. As I said, pathophysiology is primarily increased LVOT gradient, mid-cavitary gradient, mitral regurgitation, LV dysfunction, initially with the diastolic dysfunction, but in the later stages, it can lead to systolic dysfunction as well. Up to 20% of patients have atrial fibrillation and undiagnosed ischemia, not just because of epicardial disease, but because of the ultrastructural changes as well as changes in the coronary distribution, as well as the muscle hypertrophy can lead to distinct forms of ischemia, although they may not have epicardial coronary artery. Natural history is extremely heterogeneous. Male predominance outcome is improved with contemporary evaluation and management, as well as increased use of ICDs. But excess mortality is still present in, especially in young people. The sudden, a sudden cardiac death may be the initial presentation. Atrial fibrillation up to 20% of patients. Important fact is that the thromboembolic risk is higher than the typical atrial fibrillation we see. So regardless of their CHA2DS2-VASc score, we may have to anticoagulate them lifelong. Less systolic dysfunction, and these have adverse prognosis because of increased arrhythmia and sudden cardiac death. Almost 5% patients can have a purely restrictive physiology with more of diastolic dysfunction, and they are more predisposed to AFib as well as progressive heart failure without going through the dilated cardiomyopathy phase. Sudden death is probably the first time I came to know about hypertrophic cardiomyopathy as a medical student. Probably in your case too, many young athletes get a life-threatening arrhythmia, and that may be the initial presentation. However, there are several established risk factors: prior sustained VT or ventricular fibrillation, a family history of sudden death in first-degree relative, severe LV hypertrophy defined by LV wall thickness more than 30 millimeter, as well as unexplained syncope increase the risk of sudden cardiac death. Other risk factors include extensive fibrosis in cardiac MRI, apical aneurysm, LV dysfunction, that means EF less than 50%, and non-sustained VT. Now, in the last decade, there have been significant improvement that we have a currently accepted sudden cardiac death risk assessment tool, which is well validated both in European as well as American cohorts. You can simply log in online to assess their risk and recommend ICD for primary prevention based on this algorithm. Coming to the genetic part of it, SCM is largely due to variants in sarcomeric protein gene mutations. Up to 40 to 60% of them have a genetic mutation. So any patient you see, if they are not genotyped, send them for genotyping so that it makes a big difference in their life. Generally, it is inherited as autosomal dominant. So as I said, many people walking around us may have hypertrophic cardiomyopathy, may have worse outcomes if they are genotype positive. So, there are three main things. 50% of them are genotype positive. 50%, if they are positive, they have higher mortality rate and that will be the beginning point of screening their family so that we can identify them a decade earlier so that corrective measures can be instituted. So I believe it is a great opportunity for us to keep our eyes open as well as appropriately institute the guidelines. Now, 1 to 2% of them will have what we call hypertrophy mimic. These are called phenocopies. These are largely because of storage disorders or some mutation that predispose them to LV hypertrophy without hypercontractility. Now, this is distinct because these may have a specific treatment to begin with. Like, for example, Fabry's disease because of alpha galactosidase deficiency. If you diagnose them appropriately, you can have enzyme replacement therapy as well as gene silencing therapies, which are available, not widely utilized. But it is very important to distinguish these people from true genetic hypertrophic cardiomyopathy in order to give them the best treatment we can afford to offer them. 40% of them have no genetic cause identified. These are called non-familial hypertrophic cardiomyopathy. There is a lot of ongoing research. We don't know if these people will have a new variant or variant that was never identified. So it's important that sometimes we have to repeat this genetic test after a while, 5 to 10 years down the line, because more genetic mutations are being identified. Remember, these are isolated to families. So, on a larger perspective, it might not make big difference. For an individual level, it makes a big difference because they can protect their kids and the future generation if they know their genotype. When you look at the genetics, I don't want to delve too deep, but for residents as well as fellows, two genes that are the most common are MYH7, which is a myosin heavy chain 7 gene protein that is responsible for the heavy chains of the cardiac myofibril, as well as myosin binding protein C3. These constitute up to 70%, 35 and 70% of gene mutation. There are other gene mutations that involve the thin filament. You can see all of these are ultrastructural proteins for cardiac contractile function: troponin, tropomyosin, actin, as well as alpha tropomyosin. Less often, but and on an individual level, knowing the genotype will help diagnose their siblings as well as their kids early on, so that you can start screening them for development. Now, the current recommendation is to include all the available genotype that has proven to be or pathologic for hypertrophic cardiomyopathy. In addition, include those phenocopies, because those genetic disorders can be identified along with the genetic panel, so that you are upfront diagnosing it, so that you can institute clear treatment. So the current genetic panel mostly includes about 30 genes. You can add additional genes if upon request, up to another 15. But there are insurance issues with the test. But unless we start doing it, we will never understand it, and probably we are missing that opportunity. In terms of overall prognosis, sarcomeric genetic mutation positive patients have a poorer prognosis. So diagnosing them early will give you some advantage. Whereas variants of undetermined significant as well as sarcomeric genetic mutation negative patients have slightly better prognosis. Overall, the prognosis is very good. Okay, people live into their 60s, 70s, and 80s nowadays, if they are recognized early and treated. So I would say, it has a fairly good prognosis. Only thing is we have to diagnose them a little early. Now, this is the most recent updated guidelines for the management of hypertrophic cardiomyopathy. You can understand the first four recommendations, class 1 recommendations, are primarily for genetics. That is, a detailed 3-generation family history, the role of cascade testing, understanding HCM phenocopies and treating them early on, as well as the role of genetic counseling. So you can understand, if a society is putting a new guideline strongly emphasizing on genetic history as well as genetic testing, the difference it can make in the life of those patients. Treatment, mainstay of treatment is mainly beta blockers and calcium channel blockers. Second line medication could be disopyramide, again a broad spectrum antiarrhythmic with negative contractile properties. Mavacamten is a specific myosin inhibitor which has been FDA approved for last several years, but needs oversight in terms of treatment because it can reduce the LV function, and you don't want to overdose and iatrogenically cause LV dysfunction. So it needs monitoring, but it has made dramatic difference in the quality of life as well as the need for septal reduction surgeries. Up to 80% of them no longer need septal reduction surgeries. And I believe this is going to change the natural history, because 10 years, 20 years down the line, if you avoid surgery, they are not going to have more complications like further scarring, further need for, pacemaker or ICD implant. So, there is a lot, but, diagnose at the right time and send them for specialized evaluation. Symptomatic patients may need septal myectomy as well as alcohol septal ablation. Risk of thromboembolism is very high. So regardless of their Chartwell score, you have to anticoagulate them. Prevention of sudden death by ICD. And, once they get into the heart failure stage, which generally doesn't happen, you have to treat them with the standard of care treatment. Rarely, you may need transplantation for those who have refractory heart failure as well as refractory arrhythmias, because you already have that substrate, that scarred myocardium, and regardless of ICD, they can still have frequent ICD shocks and poor quality of life. Now let us delve slightly deeper into the dilated cardiomyopathy. This is probably the broadest segment as well as the most confusing. So I will try to stay a little bit more time, spend more time on it, but at the same time, I have to finish as well. By definition, diagnosis is characterized by LV or biventricular dilation associated with impaired contraction, that is hypocalemia. Again, rule out other abnormal loading conditions like hypertension, valvular heart disease, as well as ischemia. Both genetic and non-genetic variants are there. There is a growing proportion of genetic mutations being identified once we send them for up to 50% of dilated cardiomyopathy. So this is a larger proportion of people whom we call it as idiopathic or dilated or just simply heart failure, where we have a big opportunity to change their natural history. The problem with the current definition is that they are phenotype based. Data is very convoluted. Multiple etiologies are put together so that nobody knows exactly what to do next, and rather than these people are being under a single umbrella. There is more emphasis on genomics and precision medicine for accurate diagnosis as well as management based on prognosis. As I said, it's a basket of a lot of etiologies. Apart from the first genetic component, you have to rule out several infectious etiologies, viral myocarditis, HIV, Chagas disease, systemic immune-mediated diseases like rheumatoid, celiac disease, SLE, or other autoimmune disorders like Crohn's disease, ulcerative colitis. Toxic, again, brought into this category. We have to rule out alcohol as well as other toxic cardiomyopathies, including iron overload cardiomyopathies. Drugs, again, we know chemotherapy can lead to cardiomyopathy, otherwise called as chemotherapy-related cardiomyopathies, as well as other, psychotropic medications, especially clozapine, can lead to, cardiomyopathy. Now, we don't know these people, do they have an underlying genetic mutation that predispose them to these kind of cardiomyopathies? Now, there is no consensus on routinely doing genetic testing in these patients. However, there is increasing evidence that these people may be having some genetic variant that might predispose them to cardiomyopathies. Peripartum cardiomyopathy, altogether a different entity, so we will not be discussing that. So approximately the prevalence is about 1 in 350, increasing. You can imagine, again, it is more prevalent than what we call as familial hyperlipidemia. Diagnosed based on criteria, if 2 or more family members are affected with a dilated cardiomyopathy, or one family member who is affected who had a sudden cardiac death or equivalent even less than 35 years of age. Broadly classified as idiopathic cardiomyopathy, our main goal will be to re-phenotype these patients so that we can better re-stratify and give them appropriate treatment. Now, the clinical spectrum for dilated cardiomyopathy, it is a tip of the iceberg that we see. Okay, and there is a preclinical phase as well as a clinical phase. Even in the clinical phase, you can see that the LV can be non-dilated in majority of them. So what we call typically as this is a heart failure. We know the EF is down, but we never classify them as dilated cardiomyopathy for a long period of time, probably for decades, before they go into dilated cardiomyopathy, where your opportunity to give them better care is already gone. So this is very important because you don't want to deal with a patient who was diagnosed with cardiomyopathy 10 years ago, now becoming dilated cardiomyopathy. So you are losing that window of opportunity. So any cardiomyopathy, start thinking about, is this a genetic variant? Is there an underlying genetic mutation that might be predisposing this patient, if otherwise unexplained, to have this cardiomyopathy? Now coming back to our case, so after the event monitor, after discussing with the electrophysiology, I sent him for a genotyping or genetic test. I requested for both for cardiomyopathy as well as arrhythmia panel, because I already know there is an arrhythmia which is inducible, and I wanted to make sure it does not belong to the cardiomyopathy. So it's a broader panel. It came out he had a variant of undetermined significance, which is labeled as CDH2. CDH2 is short form for cadherin. Cadherin is an intercellular adhesion molecule, which is implicated in a lot of cases of arrhythmogenic right ventricular cardiomyopathy. Now, this particular mutant is described as undetermined or uncertain significant. There comes the caveat again. So if you are in doubt, there are 2 resources you can look into. They are called ClinGen as well as ClinVar. ClinGen is a private entity where there is active research and as well as data from throughout the world that is being incorporated, whereas ClinVar is a nationally sponsored database maintained by National Library of Medicine in the US. Both have a lot of mutations. You can search for it and you can find what the implications. When I looked into it, I did not get a lot of information from the ClinGen, but when I looked at the ClinVar, you can see this specific genotype is associated with dilated cardiomyopathy as well as hypertrophic cardiomyopathy. Now, the plot thickens again, correct? So, for diagnosing dilated cardiomyopathy, there is a lot of workup that you have to go through. But, I think you should all guide your clinical judgment in terms of choosing which one to do. As well as, if you are in doubt, you can send a referral so that you get a better perspective of what need to be done. A lot of them are associated with muscular dystrophies as well as neuromuscular disorders. So there is a definite overlap. EKGs, all the other clinical features, all can give some clues to the kind of workup you need to do. Here comes the importance of deep phenotyping as well as advanced cardiac imaging. Echo has been always the cornerstone of diagnosis. There are a lot of advancements which you can utilize in order to recognize these patients very early, especially the global longitudinal strain as well as tissue Doppler imaging, which can reveal specific patterns in these subset of patients. Again, the role of cardiac MRI, I cannot, underline it anymore because what you don't see on a routine echocardiogram, you will see on a cardiac MRI. There will be ultrastructural changes that lead to myocyte death as well as scarring, which you can never detect unless you do specialized imaging with gadolinium enhancement as well as T1 and T2 mapping. So again, it is an underutilized segment of our specialty, which probably with more insight we'll utilize more to better tissue characterize them. Cardiac CT in patients who do not qualify for cardiac MRI, you can still use it. The role of PYP scan as well as FTG PET, especially in infiltrating cardiomyopathy, to rule out cardiac sarcoidosis as well as amyloidosis, you may want to resort to that as well. Advanced techniques like, using small catheters. This is done in EP labs, but you understand those who cannot undergo a cardiac MRI, they can still get benefit from an advanced electro-anatomic mapping with an EP study. I did a cardiac MRI for the patient after discussing with EP. He had a mildly dilated LV and RV, mildly reduced systolic function. Again, as I said, it was low normal on echocardiogram, but for more accurate assessment, cardiac MRI will be a better choice. Both LV and RVEF was low, and he had focal, almost transmural scar in the inferior RV insertion point. I don't know if you are able to, see it very well. This slightly hyper-enhanced area is gadolinium enhancement. This is the right ventricular myocardium. This is the septum. This is the inferior insertion point. In addition, there was some additional scar noted in the mid to apical inferior wall segments. There was no diffuse scar or fibrosis. Based on the MRI findings, EP recommended an electrophysiologic study. We did electroanatomic mapping. Two PVCs were isolated, one from the papillary muscle, which was ablated, as well as one from the inferior wall. Both were ablated, and he no longer had those PVCs which were seen. He was started on metoprolol. He is scheduled for a follow-up echocardiogram to reassess his LV function. At this point, the possible explanation for my patient's presentation, is this a genetic cardiomyopathy? It is not inherited because he doesn't have a family history, but, maybe they never knew about it with additional conduction system disease. Or is this a scar from a clinically silent myocarditis, which he might have had during the course of his, lifetime? We will never know. But the importance is, because he has a variant of undetermined significance, I still have to keep an eye on it, because after a few years, this VUS may be reclassified as a pathogenic variant. So at that point, it becomes more important, his kids, subsequent generation may benefit from cascade screening as well as genetic. A lot of genetic mutations I don't want to delve deeper into, but you can see the overlap of genetic mutations for dilated cardiomyopathy to ARVC, arrhythmogenic ventricular cardiomyopathy, as well as other ion channelopathies. You see the CDH2, which was positive in our patient, is one of the gene responsible for arrhythmogenic right ventricular cardiomyopathy. These are the common genetic mutations. You know that the largest gene in human genome is of titin, okay? And everybody carries at least 0.5 kilogram of titin protein in our bodies. So you have to understand that heart muscle, one of the ultrastructural protein is titin, and that is probably the reason why several genetic mutations are. Filament C, RNA binding motif 20, desmoplakin, phospholamban, desmin. All these names are fancy, but you understand that it puts them at very high risk for arrhythmias. And sudden cardiac death is one, unrecognized entity, which we always say, sudden passing out, sudden event, but we never look deeper into to understand it better. Now, the complexity is more because not just having a causal mutation is the ultimate result. It is modified by several other genes, environmental factors, including age, sex, as well as other phenotypes. So the ultimate phenotype could be different depending on other several factors. As I said, incomplete penetrance as well as variable expressivity still is a concern. Management, mainstay of therapy, the heart failure therapies, but anticoagulation, if they have very low EF, because they can predispose them for LV thrombus and systemic thromboembolism also. Very important to stratify them for primary as well as secondary prevention. You all know the classic definition for ICD, classic recommendation for ICD is less than 30, EF, persistent LVEF less than 35%. But if you see any genetic mutation that belong to this category, lamin A, filament C, titin, desmoplakin, phospholamban, RBM20, the typical cutoffs are no longer there. You can recommend ICD even if their LVEF is 45% or even more, depending on at what age one of their family member had a sudden cardiac death event. Screening, in adults, you can easily, remember it as like, between 20 to 50 years, every 2 to 3 years. More than 50 years, all family members can be screened every 5 years. If they don't have disease, screen them again after 5 years. Genetic testing has to be recommended for the most clearly affected family members so that the diagnostic yield is high, and recommend cascade screening for family members as well. Now, this is precision medicine where you can reclassify each patient into a low risk, intermediate risk, as well as high risk. If they are high risk to begin with based on the genetic type as well as their clinical features, you can already recommend ICD. However, if they are intermediate risk of lifetime sudden cardiac death, you can recommend Holter monitoring every year in order to pick them up a little early. If they are low risk, just guideline directed medical therapy is all that is recommended. A few words about arrhythmogenic cardiomyopathies. Again, that's classic arrhythmogenic right ventricular cardiomyopathy is only a small subset of the whole arrhythmogenic cardiomyopathy. Increasing recognition of arrhythmogenic left ventricular cardiomyopathy and significant overlap with dilated cardiomyopathy as well. Specific subtype and their classification, it's not really needed just for the sake of completion. If you recognize epsilon waves on EKG, that may be the earliest sign which might help some people to be referred early on so that they don't develop severe RV dysfunction and predispose them to sudden cardiac death. The genes involved are usually the desmosomal genes, and they lead to progressive cell death. It is still unclear why the right ventricle is more involved. It can lead to progressive cell death, fibrofatty infiltration, RV dysfunction, and overt heart failure. Usually these are young people, and one sudden cardiac death event is like a life sentence for them because already the damage has already been done. If you have an underlying genetic mutation, all the family members need to be screened and rescreened subsequently. Exercise is not recommended in these people because the more they exercise, the more the phenotypic expression, even if they are gene positive but negative for any event, if they continue to exercise, it can lead to progressive RV dysfunction. Again, the management is primarily sudden death prevention, lifestyle adjustments, as well as medications, and reclassifying them for qualifying ICD. Restrictive cardiomyopathy, any discussion on cardiomyopathy should not end without amyloidosis as well as other infiltrative cardiomyopathy. So a couple of slides on infiltrative cardiomyopathies include amyloidosis, some genetic predisposition for sarcoidosis, as well as hereditary hemochromatosis. Amyloidosis, the way I look at it is it's a systemic disorder. You have amyloid fibrils, which are normal human proteins, but for some reason they are misfolded and they get deposited in different tissues. The classic form is AL amyloidosis, which is associated with plasma cell dyscrasias. The amyloid light chains, when in excess, forms fibrils that get deposited into different tissues, including your neurologic tissues, soft tissues, as well as the myocardium. The way I look at it is, no AL amyloidosis should be undiagnosed. So the best way to do it is do 3 tests: serum, protein, immune electrophoresis, urine, protein, immune electrophoresis, as well as serum and urine free light chains. Why I am clearly, underlining this is the diagnostic yield is up to 99%. That means you will not lose any patient who has AL amyloidosis or amyloidosis if you follow this pattern. And once you roll out AL amyloidosis, what is left over is the transthyretin amyloidosis. There are only 2 categories, transthyretin, whether it is an inherited form or a what we call wild type, which usually is in the 60s, 70s, and 80s. The wild type do not have any mutation. They are just like normal people as we are. But for some reason, as they get older, their transthyretin normal protein have a tendency to dissociate. It's usually a tetramer. It's called a heterotetramer. 4 different subunits form together to form a single. Older, there is a tendency for it to unfold. Once it gets unfolded, it forms myofibrils and get deposited. So the classic presentation is usually they may have bilateral carpal tunnel syndrome. They may have had a ruptured tendon because these fibrils get deposited and weaken the structure and the spontaneous rupture. Many of them have low backache for a long period of time. They might have had multiple surgeries. Still, they continue to complain of that. These are called the red flags. If you identify them, suspect wild type ATTR amyloid, because there is a specific test to diagnosis and there are specific treatment to offer. The specific test is primarily what we call the PYP scan. Okay, it's a bone scintigraphy. These fibrils have typical property of attaching to the technetium pyrophosphate, which is a bone tracer, but at the same time it gets deposited as well as seen. Classic description is Congo red stain with apple green birefringence, and specific therapy is tafamidis. So if you see an unexplained heart failure in an elderly patient who is, please think about amyloidosis. Send them for PYP scan. Send them for a cardiac MRI if you are still suspecting it, and diagnose it early so that you can institute treatment. There are 3 mutations I will be, that are specific for. There are more than 120 mutations, but I would recommend everyone to remember 3 mutations. One is the I-122, V122I. This is more common in North America, especially in the Afro-American descent. The allele frequency is up to 3.4%. That means this is autosomal dominant, but a lot of African Americans may have this gene by birth, and they may present a little bit early. The other 2 phenotypes are European variants, which has more of neuropathic presentation with peripheral neuropathy as well as autonomic dysfunction. One is the Portuguese variant, as well. The other one is Irish, people of Irish descent. Again, something you might be able to remember rather than remembering everything. These are typical echocardiography as well as cardiac MRI features. One thing which may be interesting to every one of you will be the PYP scan. If it is positive, you can see the heart brightened within the planar image with a lot of myofibril deposition within the heart. Now, although this is the typical pattern, you probably see it 1 out of 10. So when you send 10 patients, once in a while, you will see this pattern. Hemochromatosis, again, I'm not delving deeper into. It is an iron overload cardiomyopathy. Specific diagnosis will be depending on serum ferritin levels as well as tissue diagnosis, rarely with H&D stain, as well as cardiac MRI with the T2 star mapping. Specific treatment will be therapeutic phlebotomy as well as chelation therapy. A few words about LV non-compaction is classically described as myocardial trabeculations with deep recesses and spaces that communicate with ventricular cavity, usually diagnosed with the cardiac MRI, otherwise called as honeycomb heart or spongiform cardiomyopathy. Really describe. If you want to remember one, I would say MYH7, that is usually seen in some of the typical questionnaire for your board exams. CMR and cardiac MRI as well as echocardiography remains as the mainstay of diagnosis. And always remember, a small subset of people with normal pregnancy as well as athletes can have the same phenotype. They may not be anything related to genetics, genetic cardiomyopathy or subsequent risk of cardiac arrhythmias. There are several diagnostic criteria based on echocardiography, specifically Jenny criteria, Chin criteria. What it looks for is, the distribution of non-compacted myocardium as well as the compact myocardium. And again, some CMR diagnostic criteria may not be of interest for us at this point. Now, the role of genetic testing. Let me briefly tell you, the main challenge is family history is not always predictive. Some of them have expression, some of them do not have it. So it's very important that we send them to a genetic counselor so that they can tease out the bits and pieces, which on a busy clinical practice you might not be able to do. Classic forms do not have full penetrance as well as their expressivity can be very. When I say that, you can have the genotype, you may have the disease as well, but you are totally different from your father or mother because your own expression depends on a variety of factors. Other forms of inheritance is also noted other than the typical autosomal dominant. Usually genetic screening is recommended. The way I try to remember, there is a 1, 2, 3, and 4. 3 and 4 or 3 and 5 is for adults. All ages between 20 to 50 years, every 2 to 3 years. You can remember every 3 years for the most part. Anybody who is more than 50 years, screen them every 5 years for phenotypic development. If they are genotype positive and they are phenotype negative, they don't need any more genetic testing, but lifelong. If they are genotype negative, you can say you no longer have the risk of arrhythmia or cardiomyopathy as compared to your family member. So you are dismissed from my clinic. Okay, so it's that important. Always do genetic testing for the probe and then do cascade genetic testing. When you send somebody for a test, always understand that what you are going to expect. It can be a benign mutation. It can be a likely benign mutation. It can be a variant of undetermined significance. Likely pathogenic. These pathogenic as well as likely pathogenic, for the time being, those are the only people whom we need to really follow. The variant of undetermined significance, because it is rapidly evolving, after 5 to 10 years, you may have to reclassify them. We don't know if the classification changed or not to reclassify. The other two, you can dismiss them saying that these very less likely, they will develop lifetime cardiomyopathy. I cannot emphasize more on genetic counseling because You imagine you are sending or screening a family that had a sudden cardiac death. Okay. And it is a very devastating time. And talking to them regarding genetic testing, screening every family member, as well as what to expect from a genetic test is kind of a difficult scenario. So you really need people who are very well trained in order to utilize that opportunity, not to scare them away, but to give them an window of opportunity where they can think about it, get it done subsequently so that they can protect their subsequent generation. With that, I am concluding my session. I hope you all walk away with a new perspective that there are people walking around us, probably diagnosed, but not very well characterized, whom you can offer, therapy as well as counseling to screen their family members so that their life becomes easier down the line. And you are not pushing them into a state where they come back with a sudden cardiac arrest. Rather, you proactively tell them, we have an opportunity to save several of your kith and kins and, offer the best for them. Thank you. Thank you, everyone, for patient listening.
Thank you so much. Do we have any questions in the room? Let's start.
How do you order genetic testing?
So, that's why, having a specialist team is very important. You need to have because you are not just doing genetic testing, you are supposed to act afterwards. So ideally, the team should consist of a cardiologist who has strong, background on dealing with these patients. You need to have an electrophysiology team. You need to have an imaging team. This is from the cardiology perspective. You need to have a genetic counselor who can guide the family as well as patient to get the genetic testing, as well as then, post test counseling. So in our clinic, what we do is we have, some kits from the LabCorp specifically for genetic testing, and we will assign our medical assistant. Usually I talk to them, I tell them, assign the medical assistant, talk to them again, because you need insurance approval, so many other paperwork done. And then you decide what kind of genetic panel you want. You want a arrhythmia panel or a cardiomyopathy panel or a combined panel. You order it, insurance company will request for your documentation, why you are doing it. Do you have detailed family history? Is this a sudden cardiac death? So they will screen and they will approve. So these are costly tests. Previously, it used to take weeks for each test to be run. Now with the gene panels, which are usually 100 genes on an average, just for cardiac genetic testing, you can get it done in a week, in a couple of weeks. Wait for the result, and then again you will have to have another discussion with him in order to disclose what it is, and then recommend further recommendations. So it's mostly personalized for the time being. We utilize our clinic facility in order to send them. I think anyone can do it. Only thing is you need to understand. You need to just understand the intrinsic problems, the ordering it, as well as what to expect next.
How much does it cost?
I don't know the behind scene things. Okay, if it is out of pocket, it can be a couple of thousands. Insurance, from my understanding, it can cost up to $3,000 to $5,000. So many a times it can be a challenge, but I think with increasing awareness, increasing, rather than putting an ICD later on, having a diagnostic genetic testing may be more worthy, if we compare the cost benefit ratios.
Yeah. I have I do have a question in the chat area on Zoom. It's from Dr. Emmons in our hematology EMT group. He says genetic predisposition to accelerated cardiac damage with cancer therapy is of great concern to us in the Cancer Center. Are you aware of any national trials exploring this that we might participate in? And would cardiac MRI be a better screening tool than cardiac echo before therapy?
I think resource limitation will be, a concern. Utilizing cardiac MRI to routinely screen everybody for, cardiotoxicity. However, I am not aware of any, campaign or a national, trial for routinely screening them. However, I am more inclined to do a genetic testing if there is a diagnosed cardiotoxicity related cardiomyopathy, knowing that there is a lot of nuance to it. Okay. But if we can identify them, maybe we might be able to institute therapy a little bit earlier. With normal EF, it will be a challenge to convince to have a real protocol to do cardiac MRI as well as genetic testing. But if the EF is borderline or slightly low, I am not against the possibility of screening them so that we can start. Now, the treatment is the same. You start beta blockers as well as ACE inhibitor or entester ahead of time so that they don't worsen their LV dysfunction. Echocardiography still remains the gold standard because it has additional longitudinal strain pattern as well as tissue Doppler velocities with which you can prognosticate them a little better. If I see somebody who has low tissue Doppler velocity as well as reduced longitudinal strain, I put it specifically in the report so that the treating oncologists know that this patient is somebody who may be predisposed to. If they have hypertension, treat them with medication that also protect them from cardiomyopathy, like broad beta blockers as well as. So to answer, I don't have a clear answer to the question, but I think with the guidelines going to change near soon, we are all hoping that genetics can be instituted a little bit earlier so that we can reclassify them and give them a better opportunity to care for them.
And he does have one final question. It says, he says, I may have missed it, but are there any mitochondrial genetic mutations associated with cardiomyopathy?
Yes, there are several mitochondrial disorders which are common both for neuromuscular disorders as well as cardiomyopathy. I specifically excluded them because of the limitation, and genetic testing is a very good way of dealing with them because mitochondrial myopathy as well as cardiomyopathy, usually they have elevated CK levels as well as some neuronal dysfunction or neuromuscular dysfunction. So it gives some clues to diagnosis, as well as we know mitochondrial inheritance, mother passes it on to the children, but no males pass it on to the next generation. So again, it is important to have genetic counseling as well as clear pedigree analysis with which we can deal with the mitochondria. Yes, there are several mitochondrial genetic mutations that predispose both to neuromuscular disorders as well as cardiomyopathy.
That's all.